We could see you were enjoying that yourself very much, a little chest filling. We are now ready for our last session of problem solving. I will hand over to Ben Lilly from the technical officer in the Health, Law and Ethics unit of Wipro to discuss an issue on reaching the unreached, a problem relating to a medical registry for vulnerable populations. This session will be followed by an overall review of the problem solving sessions. And so over to you, Ben. We can't hear you, so someone needs to switch on your speaker or voice test again quickly.
Testing.
Perfect. There you are.
Thank you. Sorry about that. Good afternoon, everyone. My name is Ben Lilly. I'm a technical officer on legislation and regulation with the Regional Office for the Western Pacific. I'm delighted to be moderating this problem-solving session on establishing a centralized medical registry that includes vulnerable persons. I know that our fantastic group of innovators are ready to share practical ideas with potential for real impact. If you just don't mind sharing my slides, thank you. Thank you. You can move to the second slide. Now, this problem stems from one raised by one of our country officers, but it has resonance to several countries in the region. So we've decided to tackle it at a more general level. Several countries in the region are seeking to improve their health information systems and implement a centralized electronic medical registry or health record. Existing systems are often fragmented across different programs and service providers and are still paper-based in some settings. The scope and purpose of electronic medical registries differs widely, but their core objectives are typically threefold. Firstly, to accurately record and share information on healthcare usage to support the integration and continuity of care. Secondly, to estimate the disease burden across population groups. And thirdly, to facilitate health planning and financing. They often contain information including medical history, personal statistics and contact information, vaccination records, radiological images, and more. Next slide, please. The issue is that introducing a centralized electronic registry could negatively impact health-seeking behavior and access to services, particularly among vulnerable and marginalized groups. Such systems would contain sensitive information about individuals and communities that could cause harm if misused. The awareness of privacy and demands for data protection and control are increasing among the general population. Vulnerable and marginalized populations face disproportionate risk of harm from misuse due to stigma and discrimination associated with gender, ethnicity, disease or illness, and other characteristics. Some already have a low trust of government and other institutions and do not trust the health sector to keep their personal information secure and use it appropriately. Some fear that it will be accessed by enforcement agencies. They may also face other barriers in accessing electronic health systems due to remoteness, digital literacy, and other factors. And final slide, please. So the problem is, how can a country introduce a centralized electronic medical registry that covers all population groups without negatively impacting health-seeking behavior of vulnerable and marginalized groups? And the goal of this session is to generate potential solutions and start to discuss and evaluate how they could be scaled to drive impact. At this point, you can end the slides now. Thanks very much. I would like to briefly introduce each of the innovators in our group. So I invite each of you to greet us with your name and your organization, perhaps starting with Dr. James Trower.
Oh, hi. Yep, I'm James Trower. I'm head of epidemiological modeling at Monash University, and our innovation was relating to COVID modeling.
Thanks, James. Miguel?
Yes, hello, good afternoon, everyone. I'm Dr. Miguel Mantaring of the Health Promotion Bureau of the Philippine Department of Health. Our innovation was entitled Address the Stress, which is a program designed using behavioral science aimed at helping to promote and improve the mental and emotional well-being of public health workers in hospitals in our country.
Thanks, Miguel. Thuong?
Good afternoon, everyone. I'm Thượng Nguyễn, medical doctor, a deputy director of primary healthcare program, a part in Southeast Asia regional hub. Our innovation is developing an educational program in e-learning and in-person formats, including a web-based and mobile-based application with artificial intelligence to provide the student, parent, teacher, and school administrators with tailored knowledge, skill to support practice non-communicable disease prevention.
Thank you, Thuong. Ken?
Hi, everyone. My name is Ken Moriyama, and I'm the co-founder of K3. So we're a GovTech specializing in evidence-based policymaking and behavior design. So our innovation is personalization AI for digital messaging.
Thanks, Ken. Next up is Aileen.
Hello, my name is Heyoon Aileen Jang, and I'm leading a team for 50 Plus to start a business in 50 Plus employment services at Seoul 50 Plus Foundations. Our innovation utilize 50 plus workforces to solve social problems such as digital divide among senior populations, and we wanted to make sure that 50 plus continue to work and participate in the age of 100-year life.
Thanks, Aileen. Now move to Ernest, please.
Hi, everyone. I'm Ernest Royce Pilapin of Cargo EMR. I'm one of the co-founders. Our innovation focuses on empowering health workers with intuitive tools to engage the community efficiently and effectively for vaccinations. Thank you.
Thanks, Ernest. And finally, Dean.
Good afternoon. My name is Dean Johnson. I'm from ThinkPlace. We're a strategic design consultancy with offices around the world. Our innovation was around using variable reward systems, or sort of a form of gamification, to drive uptake of really challenging to shift nutrition and health behaviors.
Thanks, everyone. So we are going to tackle this firstly from the perspective of design, and secondly from adoption. So we might start with design, and the question I'd like to put to the panel is, what are some considerations, ideas, or potential solutions that could support the design of a centralized medical registry to include vulnerable groups? And I might start with James. Your innovation involved the development of a user-friendly open source platform for public health surveillance. So I'd be interested to hear your thoughts on this.
Thanks very much, Ben. Yeah, I mean, I guess our innovation certainly was a very different thing to what we're discussing in this forum. We were trying to build software that would facilitate epidemiological modeling of COVID dynamics. So there were a lot of pretty marked differences, but also some similarities in what we're discussing here. I guess one of the main lessons that we learned from our work with a couple of different countries in the Western Pacific region was that it's always important to start small and start simple and get things right from the outset. While also, I guess, keeping it's a tricky balance, because you also want to keep your eye on the ultimate goal and the strategy and the vision for where you want to be in a few years' time, but then sort of work on the first two steps in that direction and getting them really right at the start. I mean, I think we certainly fell into the trap a few times of trying to build something that did everything that we needed to, that built a very complicated model. I mean, COVID dynamics can get extremely complicated, of course, and so at times we were trying to build a model that took into account all of those dynamics, when maybe what we should have been working on is a really simple, elegant model that captured the essence of what we needed. And so I think there are hopefully some parallels in terms of what we're talking about here, which of course is a medical registry, that in a few years' time, a few years from now, we might be really looking for something that fulfills that vision of providing something comprehensive across the whole country that can be used for lots of different purposes. But in the short term, perhaps I think maybe the next 6 to 12 months, it's really important to answer, what do we want to achieve over that period of time? What are sort of some really core ingredients of the registry that we can implement now that people will use straight away? So that might be perhaps capturing vaccination, for example, knowing when a person goes to a clinic, can we immediately access just their vaccination status? Can we say when they had their COVID vaccines, for example, how many vaccines have they had? Are they fully protected? Are they protected to the extent that we would want them to be through the policies in the country that we're considering? And can we get that really working well so that we have something we've demonstrated is well designed, build some trust in what we're trying to achieve, and then sort of just do that first step along the way to the ultimate vision. They're my first thoughts. I can certainly speak more about that, Ben, but that's a first take on it.
Thanks very much, James, and thanks for the first take. And perhaps we might circle back to a couple of those,
Sure.
a couple of those lessons that you shared with us. I think in particular, the theme of building trust is really one that will permeate throughout this session, and I think was one of the key lessons learned during the COVID-19 pandemic as well, in our relation to the use of digital technologies for the response. Before we do circle back, let's move on to Miguel Mantaring from the Department of Health in the Philippines. You've done a lot of work at the sort of with our healthcare workers, and I wonder if you've got any sort of lessons that you can share with us from that experience.
Yeah, thanks, Ben. So I guess the hat and the perspective that I'm bringing to this panel this afternoon is our role in national government. So maybe I'd be one of the fewer representatives of those working in a government institution. And traditionally, we've seen government policies and programs as more of a top-down approach. Although we do have institutionalized consultative processes where we ask people what do they think about our solutions, our innovations, majority still of the components of our policies and programs are designed by people who sit in government. We sit in desks and offices majority of the work days, and we don't actually have the grounded understanding or the context of where our policies and programs are being implemented. So as the National Lead Office for Health Promotion in our country, we are guided by the Ottawa Charter for Health Promotion, which to enable people to increase control over their health and what affects it, strengthening community action is a very critical component to it. So as a young progressive in government, mirroring our Bureau's progressive stance on transforming top-down approaches to more bottoms-up interventions for maximum health impact, a critical realization for us was that government cannot do it alone. Partnership with experts and the community is critical to the success of our health interventions. And for our innovation, partnership with the pioneer behavioral design scientists in our country was a very critical component to it. So if I may just share a quick visualization of our partners' behavioral design process. So the behavioral design process develop our intervention and innovation through behaviorally and impact assessed prototypes and tools. It consisted of 4 phases. The first phase identified the problem, which included identifying who is the specific target audience and, more crucial, understanding what this target audience aspires for in relation to the health problem being addressed. So in the problem of our EMR-related problem-solving solution this afternoon, so who are the vulnerable groups that we want to target? What do they want to achieve with the solution that we are presenting to them? The second phase involves behavioral insighting. It systematically gathers further insights, which allows us to narrow down from the many possible target behaviors and zero in on specific and the most promising target behaviors by understanding what the target audience goes through as part of their routine day-to-day lives. It allows us to determine at what critical moments within the target audience's day our intervention will be best utilized and most likely be most effective to drive the target audience towards our target behavior. The third phase involves ideation and prototyping, so a participatory approach in designing the intervention, especially including the key demographics, the audiences that we want to target, allows for a more context-specific intervention to be developed. And finally, impact assessment utilizing mixed research methodologies to assess behavior change, which allows us to gain a more holistic perspective on the impact of our interventions on the target audience. So again, I guess in summary, these are skills and knowledge which are not necessarily innate to us as government institutions, but we work with those more capable and strengthen community action through participatory and collaborative development processes of our innovations and solutions. And definitely sustainability was incorporated into the design process of our innovation. So that's all I have to share for now, Ben.
Thanks for that, Miguel. That was really fascinating. And actually, before we move on, I just have a quick follow-up question for you. I can see Dean's got his hand raised as well. Why don't you go first, Dean, and then I'll follow up as well.
Yeah, my comment was just sort of, you talked about segmentation, and I think that's a really important consideration. We have done a project very similar in a different context, and I think one of the key considerations was that, I'll just quickly show something actually related to that. You should be looking at a segmentation. Sorry, it's the wrong document. It's always the way. Yeah, so it's this one here. So often when designers are thinking about designing systems like this, we can focus on one certain audience. So intentionally or unintentionally, the design can focus around, for instance, potential misusers of the intervention, or it could be focused on super users. But what we realize is that there are these different segmentations that, different segments within the population that we need to consider. And for each of those populations, we need a differentiated strategy and a different approach, both to the design, but also when we're thinking through adoption. So an example would be, typically the largest segment is those that are apprehensive, those that have concerns or risks about adoption of the product. But one solution is thinking about coupling that product with a different product that user finds valuable. Maybe it's something to do with the employment system, maybe it's telemedicine, but something that the actual consumer finds valuable. But I think the main point is just referring to segmentation and realizing that there are different ways to think about this audience, and this sort of more psychographic approach, which considers their barriers and their concerns to adoption, is a really good way to think about it when thinking about design.
Thanks, Dean. That's really interesting. I think something we might pick up on later in this session is, we're speaking about needing to reach vulnerable population groups through the medical registry, but of course there'll be sort of intersectional vulnerabilities that many of these groups will be facing. I think that sort of goes to your point there, that it's important to understand the different segments of the population that we're looking to target with the intervention. Miguel, if you don't mind, just a quick follow-up question for you as well. You spoke about how this really required a cultural shift in the government, and it was something that the government isn't used to doing, perhaps doesn't come naturally to the government. How did you convince decision makers in the government to follow this design process? What was the process there? And do you have any tips that you could share with countries that are embarking upon this particular challenge?
Ben, if I might intervene, quickly. I have a hand up, but I think it's not appearing on the screen. I just want to feed in a question by Gong Meng Chun on the Q&A box that might be discussed by Miguel or any other speaker. And the question is asked whether when implementing systems to reach the unreached or to reach vulnerable and disadvantaged populations, whether the lack of a general health or medical data standard is a barrier, and whether there is any suggestion on how to overcome it. Over.
Thanks,
then.
for
All right.
that. Thanks for the intervention, Gowden. Is that something that you feel as though you have a view on, Miguel? Do you have anything that you'd like to share in that response?
Yeah, for the first question that you raised on how we were able to talk to other government officials to support our interventions and innovations, well, a large part of our process involved having co-messengers to what we wanted to do. So we couldn't definitely be talking about it alone as an institution or as a bureau. So we had to find allies and other co-messengers who could magnify and heighten our sentiment as to why this is actually needed. The second response to that was to always go evidence-based, even though it might not be attractive to some government officials on the numbers and the science behind it. When we back our interventions and our programs with a solid evidence base, we are able to garner more support from civil societies and non-government organizations who support our calls and our messages. So I guess those are our key learnings from the first point that you raised, Ben. And maybe to answer Gowden's point, I think it is definitely critical to have a centralized medical registry, which can paint the picture of what the problem we are currently facing in our own specific contexts. So the challenge, I guess, for all of us is to come up with something more culturally acceptable and targeting those segments of the population who need our interventions the most. So those are my 2 cents for the 2 points raised. Thanks, Ben.
Thanks for that, Miguel. They were very valuable 2 cents. Might move on to Thuong. Now, Thuong, I know that your the initiative that you submitted for the challenge collected data from youths in relation to their health behavior, so potentially quite sensitive. So I wonder if you have any sort of lessons that you can share from that experience that potentially could be applied to the design of these registries.
Thank you, Ben. It's a very good question. That in our innovation, we try to collect the information from students, to get the risk behavior in terms of NCD risk behavior, like tobacco, or smoking, or alcohol use, and so on. And this information is quite sensitive for students because they will get a punishment from the school, right? If that information get from that data to the teacher and school. So it's a quite fit with the info that topic we discussed about, and I deeply understand that a centralized medical registry system is critical to finish the situation that the information is fragmented and make the delivery of the healthcare less efficient. I would visualize design from a physician perspective because as a innovation design and implementers, I more care about the population or groups that's vulnerable, like Gordon had mentioned about a very critical question, that's how to manage that data. So also my point of view to include the vulnerable groups without impacting their health-seeking behavior. A centralized medical registries must First, be comprehensive and electronic, accessible via internet system. You know, like the information from students we are collecting now, that's all collect in the cloud data and analysis by program and by applications. So from all stakeholders from Ministry of Education, Training and Media, from the government and from school administrator and from teacher, they can access the data in real time. However, it's of course it's like confidential and anonymous information. And second, the system, I think that had to ensure the data privacy and security according to the relevant law and regulations. And here, I would recommend that a comprehensive legal corridor should be established in advance, for the data protection measure to fit in. And third one, the system should allow for patient or for user to use the content of their medical information or records, including like a lab results or prescriptions. So, and the fourth, should allow patients to share identifiable information from the medical records and for the data bank, with only whom they grant access. And whatever the patient are like a medical doctor, nurse, or teacher, or service providers, he or she must sign a statement of responsibility for data privacy. It's extremely important. Like from our experience working on HIV/AIDS, is some sensitive groups such as people living with drug or commercial smoker. In most of countries they are illegal. So with that confidential assurance, they be more confident to put in and to provide us information, real information. And last but not least, I believe that the system should provide the patient or user with more benefits, such as like connecting to expected clinics or managing appointment or receiving health insurance support or subsidized, like people living with HIV. They normally get subsidized from the government, Vietnam government on health insurance to get their drug or treatment or examination through the health record, and access to the service virtually and distantly, especially in the context of COVID-19 and some distantly difficulty in terms of traveling and access to health service. So I think that the health centralized medical should be. Yeah. Over to you, Ben.
Thanks for that, Thuong. Lots of interesting points that you raised there, and a couple that would be keen to circle back to. I particularly thought it was quite interesting that you raised the benefits of the registry, and I think one of the challenges that's likely to be faced here, and I hope that Dean might touch upon this in his presentation, is that the users or the patients may not see the benefits of the registry for some time. It may not be immediately obvious to them what the benefit of this is. So how we can, how the country could demonstrate that, or how those benefits could be built into the system. I mean, that's something that's possibly quite interesting to ponder and to think about. Before we move on from the design part of the discussion, I want to just open up the floor. Does anyone else have anything that they would like to add or comment on? James, please.
Oh, yeah. Sorry, I was remembering that I don't actually have to raise my hand, but I guess just like I gave my perspective as sort of from the point of view of coming as from the innovation experience we've had, but also I'm a clinician in Australia, and I guess in Australia we've had My Health Record roll out as a national platform for storing health data, and there's been some well-publicized failures of that process. But I mean, even if it had gone better, I think one of the things that really hit home to me as a clinician working in this field and using an electronic health registry that's sort of national is how far away it is from ever replacing computational computer records in an individual hospital or an individual clinic. It will never ever do that. And so you have to acknowledge the fact that other repositories and other registries will always exist, and you're going to have to interface with them, and you're going to have to think about ways that the national registry is complementary to those. Like, for example, I do actually find my health record in Australia quite useful, but it's pretty limited in the functionality that is useful. So I'll use it to go and look up, for example, I was talking about COVID-19 vaccination. You can sort of link into that through your hospital record, but there's so much in the hospital record that a national registry would never supplant, I guess. Yeah.
Thanks for that, James. I think it's a really sort of interesting perspective that you bring from, as a clinician working in the country that recently introduced one of these systems. And I think it picks up on the theme that was touched upon in the previous problem-solving session, which relates to seeking understanding of what systems already exist and how new systems can build upon those and complement those, which I think is something that you raised. But perhaps that's a good time for us to move on to the next part of the discussion, which is on adoption. And I think it's a nice segue actually to turn to Ken Moriyama. Ken, I know that when we were discussing this issue earlier, you mentioned that something that Thuong raised was the need for sort of legal and regulatory frameworks. Look, I'm a lawyer, so that resonates with me. But I also know that can't be the whole picture. And you've spoken about the need for to create a culture of data protection. And so perhaps in your comments, you might want to touch upon that as well. But I'll turn over to you to share your thoughts on how we could drive adoption of a centralized medical registry. Thank you.
Great, thank you, Ben. In my opinion, this problem is not necessarily a technological problem, but perhaps one could see it as more of a communication problem between the central government and the citizens. And in understanding how to go about improving this communication, I believe behavioral mapping, or as Miguel mentioned earlier in this session, behavioral design process can help us a great deal. And the slide that I'm presenting here is a very simple behavioral framework that's developed by Professor Michi at UCL. It's called COMBI. C is for capacity, O is for opportunity, and M is for motivation. So the point that I want to make here is perhaps you think there's a problem with the technology or the motivation, but unless you actually map it out in a very detailed way by interviewing the vulnerables or interviewing the actual target audience, you really don't know if that's really the case. So as much as I'd like to talk about technology and data governance, I think really understanding why the target audience is not engaged with a certain policy is very important. Over to you.
Thanks for that, Ken. I think, that's a really good sort of opener to this discussion, I think, and perhaps we might circle back to you to explore that in a little bit more detail. Might just move to Ernest next from Carego. I wonder if you might have some perspectives to share on this, Ernest.
Yeah, I think I'd like to add on what Ken has said, and it's pretty much established. It's not really a technology problem, but really more of a for the people to really appreciate what's happening in terms of having this technology. What's the advantage? What are the benefits? For our experience in Caribou EMR, what we did in trying to implement this technology with the community, we did first a need assessment so that we would see if this kind of technology would really disrupt the work, would be too disruptive in the workflow of the people who's going to really serve the community. So it's really going to the interviews is what they have said. So what my fellow panelists have said. It's really interviewing the people who's really doing it every day for the community. And are the tools that we're trying to implement, are they too novel, too familiar? Which is, for example, in this community that we observed, if you're going to implement an AI for that kind of, for that community, it wouldn't be possible with them because their records were still in paper, including myself. I do not even know my vaccination records as of now. Next is the context for their culture, their language, their religion. What are their behaviors towards that kind of solution? The capacity to implement. And lastly, I think it's the trust and confidence that we have to build in terms of the healthcare system. The insights of the people who serve the community. What are their thoughts on it? When we tried to pilot our solution, we met heavy resistance at first. They thought, the health workers that we've partnered with have thought that the technology is going to replace them. But as we sought feedback, built relationships, and made it clear that the solution is not being solved for them, but with them, it's when the appreciation had started. And we have found that the points of improvement to contribute in strengthening the healthcare system can be done together and not only by one entity.
Thanks for that, Ernest. Yeah, a lot of interesting points, particularly the experience that you had encountering resistance at first when you first looked to implement the CareGo initiative. I think it would be interesting to maybe come back if we have time to hear a little bit more about your reflections on that and sort of the particular practices that you found effective. Might just move to Aileen, who I think we've spoken about this being an issue, potentially one of communication and trust. And Aileen, I'm interested to hear about how what ideas you have for how the community could be engaged in the development of the registry and also in the use of the registry.
Right, thanks. I also think in constructing medical registry, it's very important to have a strategic information dissemination plan. And in this case, you might want to identify a right group of people to reach out to the vulnerable groups. And I want to share how SOL has been utilizing 50+ workforces to reach out a vulnerable social groups. Basically, SOL has been keen on finding ways to extend work span of the 50+ generations as one of a key strategies to support 50+ redesign their life so that they can continue to work and also to participate in society even after their retirement. So we discovered that types of work that 50+ preferred were not simply a conventional full-time job. Majority actually prefer part-time, and their purpose of work pivoted from economic reasons to pursue socially meaningful activities. So we developed more than 100 work models fit for 50+, which were in the forms of like part-time and full-time internship, social contribution job activities, or volunteers that solve social problems. So one of the models that I'd like to share today is called the digital bridgers. Let me share a picture here. So digital bridger, which was introduced amid the COVID-19 pandemic with a concern that increasing digital divide among the senior adults actually create divide among the senior adults. So while younger groups who were well-versed with technology enjoyed the delivery of critical services online, as non-face-to-face services accelerated during the pandemic, it became much more necessary that the underprivileged elderly need to enhance their digital skills to protect them from being isolated and suffer from depression. So Seoul took fast action to resolve this problem by utilizing 50+ workforce. We have mobilized about 150+ generations who are interested in enhancing digital capabilities and training older adults to become a community digital instructors for seniors. Basically, 50+ workforce became an agent to narrow the digital divide among the older adults and to expand social welfare services in Seoul. Anyone aged 50 to 64 who can use smart devices were eligible to become a digital bridger. And after completing a 12-hour curriculum on educational manuals on basic use of digital devices and how to instruct digital skills for 75 or older age group, they were matched with senior adults as a digital technology instructors at senior welfare and community centers. So we trained more than 100 digital 50+ digital bridgers, and we reached out to more than 2,075+ citizens on how to use smartphones at a community level. So what we focused is on the role and characters of the 50+ generations. Since 50+ generations are both understands digital and analog lifestyles, the idea was for the 50+ generations who understand the analog lifestyle of 75+ to bridge the digital gap and help them familiarize with digital devices. So compared to younger groups, 50+ age groups are likely more patient and knows how to communicate with older people, help them navigate online. So the 75+ senior groups, the older adults, felt sense of intimacy and comfort to 50+ digital bridgers who felt less generational gap. So when we construct a medical registry system, I think it's very important to improve how the vulnerable groups can be socially engaged. And it is in doing so, I think it is important to identify an appropriate group of populations to reach out to vulnerable groups. And while we talk about very high touch digital uptake, we need to use people's power to improve social engagement of the vulnerable group to get access to digital technology. And in doing so, I think it's very important that we need to have an extensive cooperations, out of the box cooperations to work with the internet service providers, tech companies, and organizations that serve with maybe older people and vulnerable groups. I think this is what I would like to share. Over to you.
Thanks, Aileen. Very, very sort of interesting and practical, idea there. And we spoke a little bit sort of earlier in the session about the need to build trust. And, if I understand it correctly, one of the messages from your experience is that by engaging trusted people in the community, that can be a more effective way for the government or for public institutions to communicate and engage socially vulnerable people.
Right.
So I think that was one of the lessons that was learned, or that's one of the lessons that we're continually learning in health as well. So thank you for that intervention. I might move to Dean now. Dean, your initiative that you submitted for the innovation challenge dealt with a particularly vulnerable group of people, and I'm wondering if you have any experiences you'd like to share from that.
Yeah, thanks. Firstly, I think the common I suppose pattern across both this challenge and the one we addressed is that we're dealing with a user group or a population of which there's a vast asymmetry of value perception between the value that they see in what we're trying to promote versus what, let's say, the system benefit or from a development perspective, what we see as the benefit. So in our intervention, it was around nutrition, but in this case, it's obviously around registration or uptake of a registry. So if we think about that asymmetry, on one side, there's for a user the perception of the risk of engaging. It might be political risk, it might be physical risk. If you also think not just about the risk, but also about the cost, so that could be money, it could be time, it could be resources. So there's a significant amount of downside effectively from the perception of that user. And then if you go to the other side and you go, what's the value? In some of this population, and maybe a lot of this population, there might be zero. The perception of the value that this can create for them in their daily lives could actually be zero or very little. So there's a massive disparity that we need to close. And I think some of the ideas to help close that gap, if we look firstly on reducing the barriers, I mean, communication has a great role to play in being able to actually educate people on that and to demonstrate remove some of those barriers, but it is incremental. It doesn't make a massive difference in my opinion, but it does have an incremental benefit. The second is things about usability and access, so making it easy to use, simple to use. That again will reduce that perceived cost. And then on the other side, if we can try to raise the value by finding something that's a latent need or an unmet need for those users and seeing if we can somehow bundle that into the design of the intervention that we're trying to drive uptake of. So in our case, we used a gamified technique called variable reward systems, which is effectively not too dissimilar to the psychology that we see in things like Pokemon Go and other games where there's an almost gambling aspect to it that's really sticky for driving behavior. But in this case, I would say actually there's a really good opportunity to look at other sectors within that individual's life. Maybe it's the health sector, maybe it's employment, maybe it's some other social service where there's an unmet need and we can actually couple these two things together. So, could you receive 5 telehealth sessions if you register? Could you receive some form of rebate, small rebate, because you're registered to this platform? So, and research is required to understand what that unmet need is, but those types of things can then actually create true value for a user. And for me, that's sort of fundamental to driving uptake. And just quickly, there's another audience we need to consider, which is not just the uptake from the consumer, but obviously from providers. And actually, you could go further and talk about other people within the health system that play a peripheral or secondary role. But one quick insight on the providers is that, again, we need to understand that one pattern we've seen in digital health, and in particular in telemedicine, is that some providers, there is a segment where they feel like technology is eroding their social capital or their professional capital as a physician. So, physicians spend a long time becoming a physician and it requires a lot of dedication, time and expertise. And there is perception, I don't think reality, but maybe reality as well, that technology is somehow reducing the capital they have within their community. So these are the types of considerations that we need to consider if we want to overcome some of those pretty deep barriers to uptake from both the perspective of the community, but also from providers.
Thanks, Dean. And that picks up on a comment that was raised by Miguel and James as well. James from the perspective of a clinician in Australia, and Miguel, I think it was Ernest, who mentioned some of the resistance that their initiative faced from healthcare workers who were fearful that the app that they were using may sort of erode that worker's sort of scope of practice. Something you mentioned, Dean, I was wanting to just unpack a little bit. You mentioned connecting the system with some sort of an existing latent need. And that's sort of, and you mentioned the sort of gamification potential as well as one sort of avenue or modality. In your initiative, which, as I understand, was in Africa, in Mozambique, I believe, how did you go about sort of understanding what those potential latent needs for that user group were? How did you identify, the need that you might be looking to sort of couple with? Just curious about that process.
Yeah, I'll give a short answer, but in a nutshell, maybe that's the wrong way to put it, but sometimes gamification can be the last resort to create value. And what I mean by that is that, in this behavioral challenge, it was around significant shifts in nutrition and diet, of which the physiological benefit and payoff for that you likely won't see anywhere from 3 weeks to even 3 months, even 6 months, you won't see the benefit. So it's incredibly hard to get people through that phase in order to drive that uptake. So we found it very difficult, therefore, to find some other unmet need that we could then couple or roll into that change that we required. So we then lent on gamification techniques that, in short, it's part of our evolutionary psychology. It's sort of comes from hunter-gatherer, and it's a part of all of us that really wants to take risks and to achieve things. And we really see that as actually a massive unmet need or potential behavioral technique that isn't utilized as much as it could be, that really taps into that, creates an enjoyable experience for people as well, a game-like experience. But in doing so, we're getting them through that 3-week or 4-week period of which they're not seeing any physiological, psychological, or financial benefit from engaging in this specific behavior. So that's probably my short answer.
Yeah, no, thanks. That's very interesting. Look, we have a few minutes left before we have to wrap up this session. So I'd like to just sort of open up to the floor. Do any of you have any comments you'd like to make to add to what you've already spoken to, or perhaps to ask a question of one of the other panelists? Ken, please do go ahead.
Yes. Yeah, drawing from what's been said during this discussion, it occurred to me that oftentimes as policymakers or those supporting the policymakers, we like to build something that's A+ from day one. But I realized that the centralized medical registry doesn't have to be A+ from day one, or it's impossible for it to be A+ from day one, because as Dean mentioned, there exists a huge perception asymmetry between the providers and the beneficiaries. So rather than thinking that we have to build something for the community, as Ernest said, perhaps we should start thinking we got to build this with the communities, and to have the patience to realize that it's an iterative process, and that it may not be perfect on day one, but it will eventually come to a level where it can be comprehensive and it can be inclusive enough to include vulnerable and marginalized populations. So that's one thing I wanted to say. Thanks.
Just a quick addition to that as well, Ken. Yeah. I think I agree completely, because also, particularly in collectivist societies, when we start to see others using it, it can be a really strong force to drive adoption. So sometimes just starting and getting that initial early adopter crowd adopting can actually have quite a good benefit for those harder to reach communities.
Definitely. I mean, that momentum or the social norm can really drive that adoption rate. So.
Yeah, Ken, I want to agree with that as well. And I think that sort of relates to the first comment I was making right at the very start of the session. And I guess, like, sometimes when we've been developing models, we've been asked, well, can you develop this incredibly complicated model that incorporates vaccination and age and new variants and things like that? And I guess the analogy in a registry might be, can you develop a registry that includes every single possible piece of information that you ever might want to know about a patient? And I think in a lot of fields, it's hard to sort of say no to things. And sometimes the right answer to that, if you're the person developing the registry and you're asked, can you build this thing that is A+ from day one? The answer is actually no, I can't, and I don't want to, and it's not the appropriate first step. And it's so hard when we're also used to saying yes to actually say no when you're asked to do something like that.
Thanks, everyone. Were there any further comments before we wrap up, or? I can't see any hands, and we have actually reached time, so we've done a perfect job. So, look, thanks everyone. That was a really engaging session. I personally learned a lot, and I hope that the audience did as well. And I hope that some of the ideas that we explored during this session will prove useful to countries that are tackling this particular problem. If I might just summarize 3 particular themes that I took away from the session. One is to understand the need and what are the priorities. And I think that, James, you mentioned focusing on what's essential, or at least on understanding what is essential. And then a related point, the second, is understanding the context in terms of what systems already exist, and not seeking to solve every problem, but trying to leverage existing systems and complement those systems. And those, I think that those are both design points. But then in the adoption side is really, we spoke a lot about addressing the value asymmetry and the various means through which we might do that, including connecting with our latent need, co-design with the community, and then also engaging with trusted members of the community, and then some of the modeling behavior that can ensue from sort of early adoption. So really engaging session, lots to unpack. I wish we had another few hours to chat about this, but I won't take up any more of your time. So with that, we might bring this session to a close. And yeah, thanks again, everyone.
So again, a congratulations to everyone who has spoken. Thanks, Ben, for being both the moderator as well as the presenter of the problem statement of this session. It struck me how appropriate it was to have this as the fourth session, a sort of culmination, building up in a stepwise process across the previous three problem-solving sessions. For a number of reasons. One, it highlights the fact that we did not actually have a country representative read out the problem statement is not because it is fictitious, but because it is very real in one country. And we wanted to preserve the anonymity of that country. So here is one way in which innovation is directly contributing to innovation in the health improvement in the Western Pacific region. Another reason why I love this problem statement is because it introduces the concept of scale as a fractal. In one sense, look at WHO. WHO says triple billions. We want these large billions and millions of people affected, million lives collective. But there's also scale at the micro level. Scale does not just mean providing solutions for the majority, because that does not compensate for leaving minorities behind. So scale then has to readjust itself as we understand the populations that we are serving. And certainly within the spirit of the Sustainable Development Goals, leaving no one behind is very important. And I just loved the sequence of solutions that we heard from, again, this group of innovators: opportunistic inclusion, incremental iterative innovation, enabling empowerment and strengthened community action inspired by the Ottawa Charter, segmentation of the audience with psychographic tools, balancing confidentiality and system interoperability, and asking ourselves, are there technological solutions that can help with the governance? Using behavior design processes, combi, gamification, overcoming resistance by providers, using human digital bridgers. It's been a very rich and a very practical set of suggestions and experiences. Talking about the four sessions of problem solving as one block, I have to compliment and thank all the innovators, not just for this session. I repeat, it has to be that we recognize all the 29 representatives of the winners of our of our innovation context. And here is the point. I love the fact that very few of the innovators simply retreated to, if any, simply retreated to just a presentation of their project. What we heard was an engagement with the problems that the region is facing, and that speaks highly for the ecosystem that we would like to foster. And in this, I would like to quickly answer the question of Jacqueline Kitong in where she is asking, what does WHO intend to do, having identified these wonderful solutions? So we are seeing this forum as an inflection point. Up to now, between the last forum in 2020 and this one, we have largely been accumulating internal experience, identifying innovations, these 29 winners. Yes, many who are in the shortlist, who aren't highlighted here, the 9 solutions from the Million Lives Collective, and as you will see tomorrow, an inventory of innovation across the region that we are collating from a broad search that we are doing. So we would like now to find partnerships and alliances that will allow us for the next months to start working on deployment at scale. So my answer to Jacqueline is watch this space, please, because we now intend to stop largely talking about ideation and pipelines and to start thinking about, yes, let's get our hands dirty, working with our colleagues in the country offices, finding governments that are amenable to working with us on these solutions and maybe others, and to see how we can, as WHO, gain experience in implementing at scale and fostering an innovative culture within the health ministries and their partner ministries. So by this, I would like to segue into the concluding section. I'm sorry to have taken so much time, but I wanted this to be a bit of a teaser for tomorrow's session. But for now, let me re-invite the moderators convened by Jeremy to give us their quick takeaways from their sessions. Over to you, Jeremy.
Thank you very much, Gordon. I will just quickly share a summary slide of how these sessions were planned today. So in this slide, we've got the first session, which was really focusing on understanding the problem. Then we moved into the session moderated by Ivan, which was the ideation phase and looking for creative solutions. And then as we moved over to Sharon, we looked at adoption. How do we scale for impact? And finally, we concluded with Ben's session, where we looked at a more holistic end-to-end, taking it from understanding the problem to scaling for impact. So first of all, I would like to invite Chris Bates to come back and just share his feedback from the first problem-solving session and what his takeaways were.
Not a problem. Thanks, Jeremy. So I just thought I'll show very quickly, summarize what is the problem and what we were discussing. The problem that we were given from Moi in Laos is that there is currently an Excel database with lots of curriculums, policies, and legislations around particular healthcare practices. And it's owned by the WHO in that country. But where they're aiming, what would like to be seeing and looking for innovation to get there is that that database is with the local government and that it is not as cumbersome as the current Excel format. It's something user-friendly that can be easily updated with new WHO guidelines and evidence as it comes along. So we were talking through how to do that, just some live demonstration of innovation discussions. And there's two things that I think we can look at and address here, one of them being the technical response and also the process that we went through. We looked at Moi's slide here and looked at the aims and started to think through, well, what are the underlying conditions and the assumptions that are going into the aims for that? Is it that ICT is the best way? What are the things which are going to make it better hand over to governance by the last country government? Moving backwards, we were dissecting that and found some of the larger themes which came up were around ownership of the program. How is the government going to take that up? And some solutions we were thinking around were that there needs to be a task force. It needs to have multiple health areas represented, but also what is the actual implementation transfer going to look like? Because that's going to really influence how they take that up. And then understanding the motivation. And that's really key for who are the end users. So we would want to understand the end users, their motivation to be updating and using this continuously. And part of that, the other thing was reporting and dissemination of the information. That makes the tool, the ICT system, a lot more valid and purposeful. And that's something that will be seen as valuable to the end users and the owners of the database. So that's how we started at one point and started to discuss backwards about just exploring what were the assumptions and the key questions to address. Thank you. Over to you again, Jeremy.
Thank you very much, Chris. From my perspective, it was a great session, and it just shows that unless you fully understand the problem, there's a chance you might create an innovative solution that will never be used because it's not actually addressing the root cause problem that the country is facing. So this session was very good in actually breaking that problem down into its bespoke components and actually understanding the root causes. So thank you for that, Chris. We will now move on, and I'd like to invite Van to come back and give her feedback on the second session.
Thank you very much, Jeremy. On behalf of our panelist group 2, I would like to summarize our discussion. Let me start with the summary of the problem statement. At this morning discussion, we were talking about the global elimination target of cervical cancer by 2030. And there are 3 targeted, but our discussion was focusing on the second targeted, which is how to ensure that the coverage of cervical cancer screening is reached at 70%. Using the high precision screening, and which is, we agree that the HPV DNA is considered as a high precision screening test. And the problem is that this there's a high cost for country and also require trained personnel. But we also have opportunities that we have existing expert machines for other diseases like a TB, HIV, hepatitis, and recently COVID-19. We also have a pool procurement mechanism existing in the Pacific Island countries. So to move forward to the elimination target, the Pacific Island countries seek innovative options to reach the target in the context of limited resources and also underdeveloped health system. So we have a very dynamic and productive discussion this morning. We have some solution proposed by our panelists and also by our participant from the task group. That in this one, I would combine all of the contribution from participant and panelists. So 6 group of solutions. One is a financing for HPV DNA tests. Second, cost reductions. We also have a testing strategy proposal, human resources or capacity building, raising awareness, and also other aspects. So I will go very summary brief on this. So financing for HPV DNA test, the solution proposed is using taxation or using health insurance for both public and private, or set up a community care fund for assisted those who cannot afford for the screening test. And also participant panelists also mentioned that we need to be ensure that the sustainable and efficient use of limited resources, or we can advocate for the subsidizing the screening test for female health workers. For cost reduction, we can use the existing pool procurement of vaccine in the Pacific Island country to procure for Socratic for HPV DNA. But this also aware that we need to have a functioning supply chain management as well. For testing or screening strategy, our panelists propose that we can prioritization for the high precision tests for subpopulations that who have high risk for cervical cancer, and other tests like a medium or lower precision for the subpopulations. And this one, we need to have a clear definition of what is a high risk and what's low risk. And I would leave it for our lab experts. Some other panelists and participants also propose that we can use pool testing or combination of high precision testing and visualization to reduce costs. In terms of human resources, we need to build capacity for our human resources. We can take advantage of the existing health workforce, like a MCH system or village health workers. We can train our health staff, like a nurses, midwife, to educate the public about cervical cancer prevention and also how to collect HPV self-sampling. And we also need to train health staff to operate POC HPV DNA test. For raising awareness, we have a lot of innovative ideas, including targeted strategy for demand creations and also integrated into the health promotions that already existing for other disease, including COVID-19. We can integrate cervical cancer screening promotion with HPV vaccination, which means that we can target it both young girls and also their mother. We also can integrate health education on cervical cancer and HPV cell sampling tests in the maternal child health care services. We can work with young people, engage women who receive HPV test to be ambassador, champion to promote for cervical cancer tests. We can organize a health camp focusing on women's health and also the benefit or importance of the cervical cancer screening. We may have an incentive for screening mechanism when especially we can involve not women, but also men and husbands. Also, for raising awareness, we can make sure that the target of the second global strategy for elimination of cervical cancer is visible to the public, and we need to report its progress. We can have a diversified promotion tool like a cartoon video, human story, provides this video to school, workplace, and community into different channels. Apart from TV, radio, mobile phone, we can have a social network, for example. We can create an interactive AI board that is available in different chat channels already, like a WhatsApp, Viber, Telegram, etc. We can use popular social media channel like Instagram, TikTok to target younger women within the certain demographic to explain benefit and of the HPV screening and prevention of infection, and also to create demand for the testing. Not as a focus in our panel discussion, but proposed by our participants. So I also would like to present here as well. Before running in any intervention, we also need to have an epidemiological picture of the cervical cancer in each country. We can conduct research to identify barrier or facilitator to access to the cervical cancer screening to inform public health intervention. We can also learn experiences from other countries where one of these innovative ideas already piloted or implemented. Participants also propose that the testing available, but we also need to make sure that treatment services are available for those who detected with cervical cancer. And finally, but not least, the data for monitoring the progression of cervical cancer program and identify gap for intervention is also important. And from this discussion, from WHO perspective, we think that we really appreciate all these innovative ideas, and we can assist member states to coordinate different partner, different donor, stakeholder, including community, for initial discussion and planning on cervical cancer program. We can also support for pilot this solution in which are most relevant to each country. We can also advocate together with the MOH to the government for financing mobilization, or we can support for conduct situation analysis to understand epidemiology of cervical cancer in each country. And also WHO can assist with the develop indicator or tools for monitoring and evaluation. Thank you very much. And over to you, Jeremy.
Thank you very much, Van. It's incredible how many solutions your panelists came up with in such a short period of time. We will now move on and receive feedback from the third problem-solving session moderated by Sharon. Over to you, Sharon.
Yeah, thanks very much, Jeremy. I'd like to begin by thanking Dave for presenting the problem about how to increase the impact of the End TV app suite and how to be able to reach more people. In summary of the rich discussions and solutions that were presented by the 8 expert panelists, really it comes back to a few key points. And one of them is at the most at the forefront is actually about keeping the community engaged and talking and discussing with the community on the best ways forward for the app. So engaging the community and those linked to the community, such as organizations at grassroots level. And I think that this keeps in line with here at WHO, reaching the unreached. So where are the communities? How can we access them? And what's the means to be able to reach everyone with different solutions that we're coming up with. Another point was looking at low-tech solutions. So it doesn't, for innovation, it doesn't have to be high-tech. It can be low-tech solutions that are actually used by most of the community that we can leverage on to be able to reach the majority of the population. Another key point was to keep it simple. Apps don't have to be complicated. And in fact, if they're complicated, they deter people from using it. And to show the value of these tools. If these tools are saving time and saving lives, there's more likely that people would actually want to be able to keep those apps on their phone and to be able to use them and often. So that's a very quick summary of the rich discussions that we had with the panel experts. And I'd like to thank them again for their time and effort and energy into the session. Thanks, Jeremy.
Thank you very much, Sharon. I think that's a very good takeaway and a very key point. Innovation doesn't have to be technological. Innovation actually can be in many different forms, and we shouldn't always think of innovation as using technology, AI, robotics to actually solve a problem, when maybe a simple social change would have more impact. So then moving on to our final session, let me please invite Ben to speak.
Thanks for that, Jeremy. Yeah, and actually, I just received a message as well from the country office that first raised the problem that we were addressing, and they just let me know that they found the discussion really, really useful, and they've taken away a lot of ideas that they're very keen to explore further, which I think is a testament not only to the participants in that particular session, but to the organizers of this innovation forum itself. So there are a few key points I wanted to highlight, and I think there's there's a lot of commonality with what we've heard from the other sessions. Firstly, the importance of having a clear strategy, not trying to solve everything at once, and the need to engage with partners and allies to build the institutional support needed to scale up and to implement. The second is know the context and the landscape, both in terms of the users that we're trying to target, as well as the existing systems and frameworks in the country. And we heard a little bit about the importance of a segmented analysis, breaking down population groups and looking to really understand the different behavioral drivers and different opportunities that exist for different segments of the population. We also heard about the importance of engaging. The importance of understanding the context, not only from the perspective of patients, but also healthcare workers and those involved in the health system. And I think the importance of predicting and being prepared to respond to resistance and to face resistance. The third is creating value and showing that value. We heard about with this particular problem that one issue may be the asymmetry in terms of value perception, where the value of the intervention is very, very well understood by those in the health system, but that it may not be immediately obvious to those that we're looking to target with the intervention. And we heard about how behavioral sciences can contribute to an understanding of what motivations and opportunities exist. We also, one message I took from the session was the importance of being patient and scaling up, not being synonymous with a rapid expansion, but the importance of building incrementally, and iterating. And we heard that's important for a few reasons. One is that it's more sustainable. Two is that the early adopters of the intervention, may model behavior and create social norms that increases uptake in the long term. And lastly, we heard about the importance of partnering with the community, which is a theme that I think came out of all of the sessions. And we heard about a few different ways in which that could occur practically, including the use of human bridges to engage and build trust with the target user group. So I'll leave it there and I'll hand back to Jeremy. Thank you.
Thank you very much, Ben. I think what we've learned today is a lot. There's many takeaways. I hope everyone who's attended the sessions today has learned something and will be able to think through innovation with a clearer vision. On that note, I will hand back to Gordon to close the session.
And I will just simply echo your thanks, Jeremy, to the moderators, the conveners of the problem statement, everyone who's worked and spoken, worked to plan the sessions and spoken. We're only halfway through, and it is my task to try and encourage our colleagues who are online or in person to consider joining us again tomorrow. The tone of tomorrow's conversation will be entirely about what is the role of government? And we are inspired very much by the theme of innovation within the WHO Council for the Economics of Health for All. And we will even have an address by the chair of that council, as well as a keynote from the chief economist of the Asian Development Bank to lead us off tomorrow. Our task will be to ask, okay, we have a pipeline, we want to scale, but what is the role of government? Is it just to address market failures, or is it to create value in society or co-create value in society? We hope to see you there. I know that there are people who want to take the floor or make comments. I think in the spirit of stopping on time, we will end this session here and look forward to your joining the conversation tomorrow. Thank you to everyone in the front or in the back office. We are only so grateful for the proceedings, the content. I think if it's possible to have a virtual applause. Today was the award day. Thank you to so many innovators who have shared their expertise and their time, who have engaged with our innovation challenge. This was your day. This was the award day. And we have learned so much from your experience. Think of this as the first step of a continuing collaboration and partnership. Today, the first day is closed. Have a good afternoon, evening to all. We see you tomorrow.